Welcome to this special episode where we collaborate with the Association of Home Care Coding and Compliance for their monthly 30-minute session, a panel discussion on a crucial topic that has been requested by our listeners. So today we delve into the realm of hospice coding. And proper coding and compliance in hospice care are so important. I'm going to turn this over to Jan Milliman of AHCC on this episode. Thank you so much for listening.
Today, we're talking about diagnosis coding in hospice. And now I'd like to introduce our industry guests for this episode. We have Kelly Kavanaugh, RN, HCSD, HCSH, HCSO, BCHHC, AHCC Advisory Board member and Quality Assurance Specialist for Riverside Home Health and Hospice, a division of the Pennant Group, with us on the call today. Kelly has been in home health and hospice for 30 years. She's worked as an agency owner and administrator, DON, done billing claims, been a field nurse, done marketing, served as a director of education, QAPI, and OASIS review, and coding. And we also have Nanette Minton, RN, HCSD, HCSH, HCSO, AHCC Advisory Board member, and Senior Clinical Coding Manager with Mac Legacy on the call today. Nanette has served in a leadership capacity for over 20 years, holding a variety of roles in the home care and hospice industry, including clinical, administrative, consulting, education, and agency startup and development. Thanks so much for joining us today, Kelly and Nanette.
You're welcome. Glad to be here.
Let's kick things off with a couple of poll questions. So we're doing quiz questions again this time. Those worked out really nicely last episode, so I'm excited to try this again. So our first question for our listeners today is senile degeneration of the brain, G31.1, appropriate as a terminal diagnosis? And our answer options are yes or no. So I'm letting this, okay, I see folks are voting now. I'm going to give it another few seconds to let folks think about this and get their answers in, and then I'll move on to the next question. All right, votes are still coming in. I need some like jaunty poll question music or something for the background for these. All right. Let's see. Okay, yeah, folks are still voting, so I don't want to cut it too short. Okay, it looks like things are starting to slow down. So I'm going to close this poll out and then we'll ask the second question. All right, and our other question for today is, which diagnoses need to be included when coding hospice claims? And your answer options are only the terminal diagnoses and related comorbidities, or all known clinically significant diagnoses. And folks are still voting, so we'll give it a few seconds to get those answers in. All right, it's coming a little speedier this time. I think it's starting to slow down. All right, I'm going to close out those polls and we'll take a look at the answers a little later in this episode. All right, let's move on and get the discussion started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many questions as we can. Our topic today has been suggested by several listeners, so I want to say a thank you to those of you who wrote in to ask us to do a session on hospice coding. Nanette and Kelly, I'm going to turn this segment over to you. I'll let you know if we receive any questions from our listeners, and I can page through the slides. So just let me know if I need to advance.
Okay, thank you, Jan. All right, today we're going to talk about hospice coding, and we're just going to kind of hit some highlights and talk a little bit about hospice and how the coding is a little bit different, shall we say. It's still the same coding. We still have the same coding rules and guidelines, and the coding clinic advice and all that is the same, but there's some nuances that we have to talk about when we're dealing with hospice that are different than dealing with home care and home care coding. So the primary terminal diagnosis is probably the biggest single item that is drastically different than home health, because the primary terminal diagnosis is the diagnosis that is most contributing to the terminal prognosis of the individual patient. The primary diagnosis also has to be the same on the CTI, or the Certificate of Terminal Illness, the hospice plan of care, and the UB04 claim form. So that's a little different than in home health. So they do have to match. It has to be the same across the 3 items. And codes for signs and symptoms, as opposed to diagnosis, they are acceptable for reporting purposes when related to you don't have a definitive diagnosis that's confirmed by the provider. But generally, we should not use symptoms or signs as a primary diagnosis for supporting hospice terminal prognosis and care. So if you think about that, you want to get as specific as possible and have an actual diagnosis, if it's at all possible, to support that terminal prognosis of your individual. Okay, next slide. So then we have related conditions. So related conditions is defined as conditions that are any physical or mental diagnosis that are related to or caused by either the terminal diagnosis or the medications used to manage the terminal illness. So these are things that are related to that terminal diagnosis, whatever that is. So we want to, for sure, add on the codes for any related conditions that the patient has that go along with that terminal diagnosis. Next slide.
We did have a question that kind of relates to this, so I'm going to pop in with it real quick. How does CMS know whether or not a hospice diagnosis is related to the terminal condition?
They're not going to know from your claim, from just a list of diagnoses, but those kinds are the kinds of things that you're going to write up in your narrative notes, most specifically the narrative note that ends up on your certificate of terminal illness. That's where you're going to have that narrative that kind of explains exactly your clinical picture of what's going on with your patient. So all those things that are related, you're going to kind of summarize in that note.
Yeah, and I'm going to jump in here just for a second, Kelly, also, and just add that, one of the things too that in addition to that, on that CTI, and we'll get to some of this, which is, this is some of the gray area that is looming over the hospice industry, I will say, that's very confusing because what one hospice may consider related, another hospice might not. So you have to be very appropriate with your IDG. When you admit a patient, you talk about what's happening, what are the things that are contributing to the decline of the patient. So it's not necessarily always related to that one diagnosis, but the bigger picture of things. And then really the medical director should, or the attending physician should, document the things that are unrelated after that team, discusses those things. And of course, if the family requests an addendum, and those kind of all go hand in hand and really should match. And I'll talk a little bit more about that later, but I just wanted to kind of mention to make sure that the medical director's documenting what would be considered unrelated. And I'll give a couple examples whenever we get to that other section. So sorry, Kelly, I just wanted to jump in on that.
That's great. I'm so glad you did. But yeah, we will discuss a little bit further down the line some things that'll make it more clear.
Great, thank you both.
You bet. Next slide. Okay, so then we're talking about secondary or comorbid diagnosis, and this is, hospice will report all diagnoses identified in your comprehensive assessment on your hospice claims, and these would be things that you're going to pull off of an H&P. The physician's diagnosis of what he said is going on with the patient. So this would be mental health disorders, any conditions that would affect your plan of care. So this is kind of that all-encompassing list, if you will, of all the things that could be going on. And what you're doing by adding all of these things on, not only is it technically a requirement that you add all diagnoses that are identified for this patient, but you're painting that clinical picture. And all of those things are helping to support why your patient is terminal, why do they need so much care, what's going on with them, and all the things that are going to contribute to the decline of the patient. So it really helps to support that terminal prognosis and to show that holistic picture of your patient. And then again, if the hospice patient has diagnoses that are unrelated to terminal, you still would want to document those and code those and have those on your claim. But that's where you would want to point out that maybe those are the unrelated diagnosis to that, to the terminal, and that you might not want to be necessarily focusing on with your hospice care. Next slide.
Awesome. Thanks, Kelly. I'll pick it up from here. So just a little bit about that primary and secondary diagnoses, just to clarify, since we had the question, and I'm sure one question can create more questions related to that. So a couple of examples, and there's no way, we need about an 8-hour session to do all of the training for sure, plus that. But when you think about, I'll give you an example. So let's say a patient was referred for congestive heart failure. The patient also has hypertension, CKD, they have diabetes. And so we know what that coding sequence is going to look like from, if you're a coder, you're going to code the hypertensive chronic kidney disease with heart failure code, and then add the heart failure, and, and then go so on down the line. Well, technically, the diabetes is not related, but we have to keep it in that same sequencing from that. And so, that's one of the challenges, is because sometimes the sequencing guidelines, we think, oh, is that related? It's not related. Well, just because it might follow a sequencing guideline in that example doesn't mean that it's related, or that hospice should be responsible for paying for diabetes medications. So let me give you a couple of things, and this is not required. It's not an industry standard, but to me, when you are doing your coding for hospice, it makes more sense, and it can be helpful when you, on that claim, if you code all the related diagnoses first, and then put like a Z51.5 code, that encounter for palliative care. It's kind of a stopping point, just a period, and then you can list your unrelated diagnoses below. And like I said, it's not black and white. It's certainly a discussion that needs to be had with the IDG and the medical director. So another thing to think about, though, hospice manages lots of symptoms. So if pain from, a lot of arthritis pain is contributing to the patient being bedbound, but that may not be their primary terminal diagnosis, hospice is still going to take care of the pain issue. So pain, anxiety, constipation, sleep disorders, all of those things, when you think about the symptoms that are being managed, that is, what needs to be coded as related. And again, it's not always going to be a black and white decision. I'll give you another example. Patient referred for end-stage COPD. Because of the COPD and the high doses of steroids, the patient now has secondary diabetes. In that case, it would be very appropriate for hospice to be responsible for the conditions related to the secondary diabetes, up to and including the medications, because it was caused from that primary terminal condition. So many things can be related to that initial diagnosis, but let's say a patient has dementia, they have a UTI, they recently fell and fractured their right hip. That hip fracture is probably greatly hindering and contributing to the decline. So, although technically a fracture is not related to dementia, again, you've got to think about the bigger picture and what's happening with the patient. So anyway, I hope that that is at least helpful and provides a little bit of guidance on that. So can a diagnosis change happen in hospice? And yes, it absolutely can. one of the things that is challenging is sometimes people think they can code the hospice start of care once, never look at it again. And so you have to be careful about that. There may be wounds that need to be on there that are healed, or new wounds that weren't there when the start of care occurred. Maybe the patient now requires oxygen or has other things that need to be added to that to support that diagnosis. But if you need to make a diagnosis change, it can be done anytime, but should be documented in the medical record along for the rationale. I always think it's best practice to have an order or very clearly outlined on the IDG that would be electronically signed by that physician to change that terminal diagnosis and to determine that date. So, you know, the date that that order is written should be the date that that change is effective on the claim. And so that can get a little tricky as well. Okay, next slide, Jan. So symptom coding guidelines. Again, as Kelly pointed out, we don't want to code any symptoms inherent to the disease process, but there are times when adding those symptom codes can support the coding. So just like in home care, you know, we're creating a set of codes to support that episode of care. We're creating a set of codes that tells the story about why this patient is appropriate for hospice. And so on this next slide, we have just a couple of things that you can add, diagnosis codes that support the terminal prognosis. So these would be things like incontinence, bowel and bladder incontinence, difficulty swallowing. Let's say you have a patient who has CHF. We wouldn't code the edema, obviously, because that is inherent to the disease process. But if they have ascites or generalized edema and asarca everywhere, then we definitely want to add that, because that is a different picture, and not every CHF patient has that. Think about anorexia, just if the patient is no longer eating or drinking. Are there changes in respiration? Are there changes in skin? Weight loss, cachexia? Are they now wheelchair or bedbound? Do they use oxygen? That type of thing. So think about the picture that's being painted by those particular diagnoses, and that would help for sure. So a couple of things that are still problematic areas in hospice coding are the use of those symptom codes inherent to the disease process. So as we talked about, we would want to not add those. A couple of other examples would be a COPD patient and having, you know, shortness of breath. Well, that would be an expected symptom with a COPD patient. Another big problematic area is not correctly capturing dementia, and I'll pause on that till this next slide. We'll talk about that. The incorrect use of combination codes, particularly hypertension, CKD, and hypertensive heart failure. So many times when a referral is made, the referring physician and or other practitioner might think, well, I referred them for congestive heart failure. That needs to be the first diagnosis on the claim. What they may not understand is that the ICD-10 coding guidelines were mandated by HIPAA, and those are across all settings, including outpatient. So we have to follow those sequencing guidelines. And so sometimes it's just explaining those things to the referral sources and making sure they understand that if they ever question that. There's a lot of questions sometimes about primary and secondary cancers. I have seen many times where a patient is referred for secondary cancers that have come back after the primary was resolved 10 years ago, and I'll see that primary, let's say it was a breast cancer that the patient had a mastectomy and everything was resolved, the patient was in remission. 10 years later, we have bone and brain cancer, and I will see where they will put the breast cancer as primary, when that's not really appropriate unless the breast has reoccurred, or is in another location, but still that primary site. So it's more appropriate then in that case, we would want to code those secondary cancers. Again, think what is the actual diagnosis that's going to contribute to the decline, followed by a history of breast cancer, that kind of thing. A lack of understanding of coding end-stage liver or heart failure. Again, just knowing what to put. Sometimes with liver patients, you might have cirrhosis, but then you might have documented also failure of the liver. And so you want to add all of those and watch your sequencing and your excludes 1, excludes 2, but just make sure you're adding all of those diagnoses. As well as heart failure. There's a code for stage D or end-stage heart failure. But we cannot code that even in hospice unless the documentation specifically outlines that. So we want to be careful about that. Another thing I see in hospice is the use of acute CVA versus sequela or late effect. A patient who has had a stroke 2 years ago and is bedbound with maybe right-sided hemiplegia, dysphagia, has had a lot of weight loss, multiple infections, rapidly declining. In that case, we're not going to use the acute CVA code because this is something that is a late effect that it had previously. The only time it would be appropriate to use an acute CVA code in hospice is if the patient had a massive stroke. Many times those end up turning into cerebral bleeds, and truly the patient never regains consciousness, and they only have a few days, so they have definite encephalopathic changes and things that you have to really document. So this is not the patient who had a stroke 3 months, 6 months, a year ago that's declining. This would be the acute CVA, and that's the only time that would be appropriate to use in the hospice setting for that. Okay, for dementia, the dilemma of dementia. So as we finish up our conversation here, I want to just clarify, we know dementia is still unacceptable as a primary terminal diagnosis for hospice. We know if they say senile dementia, we also know if they say vascular dementia, that it's excluded as a terminal diagnosis for hospice. So what are we as providers to do? And so definitely we want to ask that physician practitioner. You want to see if, are there neurologist records? Are there other things that we can look at? And hopefully there are, but sometimes there is not. So when you think about vascular dementia, that's usually a multi-infarct, a type of dementia that's occurred because of vascular changes in the brain after lots of strokes. So hopefully you can reach back out if vascular dementia is stated and ask, okay, do you know what type of vascular disease is causing, cerebrovascular disease is causing this? Have they had strokes, or do we just need to use other vascular, other cerebrovascular disease followed by the vascular dementia? And so those are questions that you have to discuss with the medical director and or the referring physician. Now, I realize there's the charts. They refer you, the patient's 92, she's never had any testing. They know that she's had dementia for 15 years, but nothing has ever been done. In those particular cases, if the physician is not comfortable stating this is, an Alzheimer's type dementia or some other specified type of dementia, we can use that G31.1 senile degeneration of the brain. But I will tell you, this is not to be used in lieu of another specified type of dementia. So if Alzheimer's is listed, that's what you need to go with versus the G31.1. In addition, all the qualifications that a patient must have in order to be eligible for hospice have to be met. You can't just use G31.1 because they don't qualify under other dementia types. They still have to be a 7A or beyond on that FAST scale, have infections, showing a rapid recent decline. So there's a lot of things that we need to capture for sure on that. Okay, as I finish this non-allowed primary diagnosis codes, again, just to reiterate, we know this has been some time, but these are going to be returned to the provider, RTP, for debility, failure to thrive, unspecified dementia. And again, we know those we know we get referrals for those, but they cannot be primary. So you've got to have those conversations for sure to be able to reach out and understand, because you want to be able to support that claim and support that that patient does indeed have a terminal diagnosis. So anyway, thank you so much. Jan, did we have any other questions?
We did have a couple come in. One goes back a little bit to the physician documentation. If the physician documents specific diagnoses or medications that are not related to the terminal condition, but doesn't say why they aren't related, does CMS ever notify the hospice or ask for further information?
You know, that's a really good question. And Kelly, jump in if you have any thoughts on this. I've not seen them question that, to be honest, if the documentation is clear. But I would think it would need to make sense. So unless it's just something that doesn't make any clinical sense, I've not seen where CMS has reached back out and said, no, you should have covered this. Now, I know what CMS is looking at as well, as they're looking at Part D coverage. You know, there's a lot of things going on over here that people might be getting paid for when they don't fully know patients on hospice care or patients getting medications that hospice should be paying for. So I have a feeling at some point all of that, the stars are going to align and they may begin to question that. I've not seen it yet.
Yeah, I agree.
Thanks. And one other question. In the instances of heart failure as a terminal diagnosis, but the patient also has hypertension, should agencies list the terminal diagnosis as hypertensive heart failure, or go with the heart failure and just add a note regarding the coding to the chart? And I think it says agencies/CTI.
Sure. Yeah, and that's where the CTI may look a little bit different than the actual coding, but the coding guidelines, if CMS pulls that claim, you're not going to be you're violating a regulation if you don't follow the coding guidelines. So you need to code the hypertensive heart disease with heart failure. So that I11.0 would need to be primary, followed by that heart failure. You know, and certainly you could put a note in there about coding guidelines if you like, but there shouldn't be a question, because that's just a assumed coding rule. Kelly, what do you think about that?
I think it would be fine either way, as long as you have, you know, a good documentation. I mean, that's kind of the name of the game in just about any industry in healthcare anymore. It's all about the documentation. So if you've got good solid documentation, I think it comes down to semantics, whether your CTI says CHF or if it says hypertensive heart failure. I think it's just semantics. But again, you just need to be sure that you have everything documented appropriately on your chart.
Exactly, and follow those ICD-10 coding guidelines.
Yes.
Great. Thank you both. So much good stuff there. Let's take a quick look at our polls just to see how those panned out. So our first question was, is senile degeneration of the brain, G31.1, appropriate as a terminal diagnosis? And the correct answer for this was yes, which 60% of folks chose. So 40% picked no. Kelly, Nanette, any thoughts about those responses?
Well, it could have been perceived as a trick question. I don't know. People may have been reading more into what we were asking, because I mean, just on the surface level, yes, it can be. But like Nanette pointed out, if you have Alzheimer's listed, then you would not be able to use senile degeneration of the brain as a terminal diagnosis in that situation. So there may have been some things other people were reading into the question.
Gotcha. All right. It's never easy in the
Correct.
world of coding. All right, and we have our other poll. Let me share those results. And that question was, which diagnoses need to be included when coding hospice claims? And the correct answer was all known clinically significant diagnoses, which 76% of folks chose. And we had 24% of people that chose only the terminal diagnoses and related comorbidities. Any thoughts on that one?
I'll take this one. So again, I think it's just understanding where we're at in the industry, because coding is not tied to payment, and so sometimes it's just a matter of, we're get in there, we're going to just add all of our hospice codes and not worry about the other, and that's what we used to do. But then CMS came back and said, no, you need to code all diagnoses, whether they're related to that terminal diagnosis or not. So, and again, it's just, we're trying to get that education out there, because again, not all providers are aware of that.